but we have some great smaller trials that are really going to build upon the information we have that will lead to larger trials in the future and really add to our wealth of experience, really helping us shape the treatment of patients with GYN cancers.
Yes, absolutely. And building on some of the research successes in the past, this notion of the MSI high mismatch repair, because immunotherapy is a cornerstone for gynecologic oncology. And so I was wondering if you can tell the audience about an update on your Keynote 158 study.
Yeah, we presented the update on Keynote 158, the endometrial, the
Yes.
MSI, to your point, the MSI high or the MMR deficient population. Last year at ESMO, we increased the response rate 48 or 47 up to 50%, so one more response. But what's really interesting about that, and we should be seeing this publication shortly to dive into the details, is 2/3 of the patients had long-term disease control. Now I know cure is a scary word when we're talking about metastatic recurrent cancers.
Yes.
But we are seeing patients in all of our practices, right, who are potentially cured with metastatic recurrent MMR deficient uterine cancer, endometrial cancer. So I think, but where is it best utilized? I still think it's best utilized in the first line setting. So as proud as I am at Keynote 158, best place to use it is up front in that first line setting. Let's start curing more patients with metastatic or recurrent uterine cancer.
Absolutely. And I think that's very important because it's, sometimes as oncologists, we're scared to use the word cure, but that's what our patients want to hear.
Yeah.
Right?
Absolutely.
Yeah.
I mean, we need to start talking about that. Instead of saying hazard ratios and median progression-free and overall survival, let's say what's the chance this new regimen increases the rate of getting rid of your cancer so it doesn't come back. If it's 10% versus 30%, if I'm the patient, even if the hazard ratio is only 0.65, I've never had a patient say, oh, the hazard ratio is 0.65, I don't want that medication.
Yes.
But if I say, here's the curve that I want you on, here's the curve if you don't get this treatment, they know that resonates with them. What's the chance to control that disease long-term to the point of even curative intent?